Starting part 5, unit or objective 33 says identify the process of role transition and discuss maternal tasks during pregnancy. This starts on page 230 in your book, which would be in chapter 11. Maternal adaptation to pregnancy. The first thing mom needs to do is actually accept the pregnancy. Then she'll begin to identify herself with a mother role. She'll start reordering her personal relationships. She'll look at her relationship with her own mother and decide if that's the type of mother she would like to be. She'll also determine the relationship with the father of the fetus and if she really wants that person to be a father figure for her developing baby. She'll begin establishing a relationship with the fetus. There's 3 phases women typically go through. The first one is I am pregnant. It's very narcissistic. The phase 2 is I'm going to have a baby. Again, still very narcissistic and focused on the mother. And phase 3 is I'm going to be a mother. And that's where she separated herself from the fetus that is growing inside her. She'll also need to prepare for childbirth. She will ask individuals that she trusts about childbirth and what to do during childbirth and motherhood. She may also choose to attend childbirth education classes. Just like the mother adapts to pregnancy, the dad also adapts to pregnancy. Paternal adaptation to pregnancy. Some men experience something called Conveyed syndrome, where men experience pregnancy-like symptoms like gaining weight, like nausea and vomiting, pica, are all very common signs and symptoms of Conveyed syndrome. The emotional response to paternal adaptation to pregnancy, there's the announcement phase, where I am going to be a dad. It's accepting the fact of the pregnancy. The moratorium phase, we're adjusting to the reality of pregnancy, where it's like, ooh, I'm going to be a dad and I don't have this and this and this and this and this done. And then the focusing phase, and that's usually in the last trimester when the father begins to think of himself as a father instead of just a single or married man without children. He'll also begin to identify with the father role, and that is typically based on the relationship with his own father. He may reorder his personal relationships, and this may include rivalry with the fetus about the time and attention of the maternal care. He will start to establish a relationship with the fetus, including kissing the maternal abdomen and talking to the fetus. And he will also begin to prepare for childbirth. And it's important as a nurse to stress the importance of childbirth education to both moms and dads. Sibling adaptation, it depends on their developmental level. You may have jealousy, you may see regression, like somebody who is potty trained all of a sudden now starts wetting the bed again, somebody who has been off the bottle for a year all of a sudden want to start drinking out of bottles again. Grandparent adaptation, they may have feelings about getting older. It's important for you to ask the woman who is pregnant about feelings of either support or non-supportive behaviors from her parents and also her significant other's parents. Prenatal care usually begins in the first trimester of pregnancy. The visits are usually monthly till about 28 weeks gestation or about the 7th month. Then visits go to every 2 weeks until 36 weeks gestation, which is the end of the 8th month. And then visits are weekly from 36 weeks gestation until birth. The first prenatal care visit includes the physical examination, the prenatal interview, which is typically done by the nurse, and laboratory testing. And this is on page 239 to 241 in your book. In the prenatal interview, again, this is usually done by the nurse. The nurse will ask questions for the reason for seeking care, the current pregnancy, when was her last menstrual period, how far along does she think she is, her reproductive history, has she been pregnant before, has she had any abortions, her health history, does she have any underlying disease processes, her nutritional history, what pharmacological or herbal history she has, because that can affect the developing embryo, her family history, did her mom have preterm labor, did her mom have preeclampsia, what about her sister, is there breast cancer that runs in the family, does she have any social, or experimental, or occupational history that needs to be divulged to the nurse, and that's again to look for exposure to teratogens. History of physical abuse, and also the review of just the body systems. Using Nagel's rule, when is a client expected to deliver if her last menstrual period began on March 15th? You would count back 3 months, which would be February, January, December. Add 7 days, so it would be December 22nd. The physical examination, the nurse would collect the height and the weight, do a BMI calculation. The full head-to-toe assessment is usually done by the healthcare practitioner. The nurse's responsibility is setting up the needed assessment tools such as the speculum, Coltrette tubes, the Doppler to listen to fetal heart tones, the tape measure so that the practitioner can do a fundal height assessment. That's all the nurse's responsibility is, just setting up that information so the healthcare provider can use it. Laboratory tests, very common first trimester laboratory tests during pregnancy include CBC, a blood type with Rh and antibody, rubella, a urinalysis, a chem panel, pap smear, sexually transmitted infection screenings, and HIV screenings. In the second trimester laboratory test, this includes your maternal serum alpha-fetoprotein for the risk for Down syndrome and neural tube defects, and screening for gestational diabetes. In the third trimester, the laboratory tests that are typically done include the group beta strep culture, which is done between 35 and 37 weeks gestation, and we may need to rescreen the individual for HIV if they've had high-risk behaviors. Again, this is just an overview of the content and timing of the routine prenatal care visits, including the first visit, what is done both laboratory and also physical assessment. With each return visit, there'll be a chart review, an overview of the history. There'll be a focused physical assessment, including vital signs, urine, weight, and fundal height, and also possibly doing dipsticks for urine. Again, this is just laboratory testing that may be done within the third trimester. Objective 33, at each visit, the patient will have their height and weight, or not their weight, height, but weight and nutritional status will be assessed. They'll have their blood pressure and vital signs taken, and also assessing for fetal heart tones. There'll be a urinalysis for glucose and protein. The fundal height will be measured. And again, that's measured in centimeters. At 20 weeks gestation, the height of the fundus should be at 20 centimeters, and it should increase by 1 centimeter per week until the delivery of the baby. The nurse should review fetal development and fundal height. They should give the patient some anticipatory guidance. In the next month, you can expect this and this and this and this and this. If this happens, you should do this. If this happens, you should do this. If this happens, you should consult the healthcare provider. The nurse should assess for any personal or family adjustment to the pregnancy. If the patient is having any discomforts and signs of potential complications occurring with the pregnancy. Danger signs during the first trimester that should be immediately reported to the healthcare provider include abdominal cramping or pain, vaginal spotting or bleeding, absence of fetal heart tones, dysuria, frequency and urgency, fever, chills, and prolonged nausea and vomiting. Danger signs during the second trimester include abdominal pain or pelvic pain, absence of fetal movement once the mother is feeling daily movement, prolonged nausea and vomiting, fever and chills, dysuria, frequency, urgency, or vaginal bleeding. Danger signs during the third trimester include abdominal or pelvic pain, decreased or absent fetal movement, prolonged nausea and vomiting, fever and chills, dysuria, frequency and urgency, vaginal bleeding, signs and symptoms of preterm labor, vaginal spotting and bleeding, signs and symptoms of hypertensive disorders, absence of fetal movements, or absence of fetal heart tones. Anticipatory guidelines that should be done with each prenatal care visit, and this is on page 254 to 256 and also on page 250 to 253 in your book, including reviewing nutritional guidelines based on the trimester pregnancy, reviewing the exercise recommendations, such as not holding their breath during the second and third trimesters, review of personal hygiene, good perineal care, just general hygiene practices, prevention of urinary tract infections by making sure they're having enough fluid per day, Kegels, promotion of dental health, because we know that dental health does have a direct relation to some overall, especially cardiac disease. Body mechanics and posture because of the stretching of the ligaments. Travel, usually travel is not recommended in the third trimester. Employment, if they spend a lot of time on their feet, they may have signs and symptoms of preterm labor and they may have to go on reduced hours. The importance of rest and elevating the feet at the end of the day. Clothing should not be restrictive or constrictive to make sure that we get adequate blood flow. And then again, just looking for discomforts of pregnancy and what the nurse can educate them on to help prevent those discomforts of pregnancy. here are just some basic symptoms of pregnancy: fatigue, getting a nap in if all possible, um, emotional liability, which is just ups and downs of emotions. That usually does even out a little bit as the hormone levels start to um, stabilize. Supine hypotension, we don't want any individual who is pregnant laying on their back. The respiratory, they may have to sleep in a slightly elevated position, either with the head of their bed elevated or elevated with pillows. Itching, they should lotion their skin very, very well. Leg cramps, warm baths, changing positions, massaging the affected area that has cramps. If they have hot flashes or hot cold sensations, they should dress in layers.